All right, diving into some really fundamental stuff today, how your body makes, the very essence of life.
Blood cells.
Yeah, blood cells.
Yeah, hematopoiesis.
Hematopoiesis.
Right.
And then we'll get into what happens when this amazing system goes awry and the meds doctors use to help. You sent over this really detailed presentation on antineoplastic and hematopoietic agents. So our mission is to distill that core knowledge into something clear and engaging about this whole vital area.
Right. So we're looking at, how these crucial cells are created, what triggers their production, and then, how various drugs come into play to help manage both shortages and in the context of cancer overproduction.
Okay. So hematopoiesis sounds complex, but it's basically your body's blood cell factory going nonstop. What are the absolute key things to get about this process?
Well, it all starts with these master cells in your bone marrow called stem cells. And these are the incredible originals that can turn into any type of blood cell. Red cells to carry oxygen, white cells to fight infection, and platelets to stop bleeding. And the crazy thing is how adaptable this factory is. Like if you're battling an infection, your white blood cell count can increase tenfold. And if you experience blood loss or low oxygen, red blood cell production can surge fivefold.
Tenfold, fivefold. That is an amazing level of response. So what keeps this whole blood cell production line running so smoothly?
Well, think of hormones and growth factors, like the management team for this factory. They're constantly sending signals, regulating the production and development of each blood cell type, making sure you've got just the right amount, perfectly balanced.
Okay, so when the body needs a boost in, certain blood cells, that's where these growth factors come into play.
Right. Exactly. They're like targeted messengers. They tell those specific blood cell lines to multiply and mature faster. And they're essential for helping the body recover when blood cell counts are low or when there's an increased need because of, illness or injury.
Our notes talk about this thing called erythropoietin. What is that?
Erythropoietin, also known as EPO. It's this hormone produced mainly by your kidneys, and its job is to kickstart red blood cell production in the bone marrow. So picture this. When your kidneys sense those oxygen levels dropping, maybe from high altitude or blood loss, they release EPO to tell the bone marrow, hey, we need more red blood cells, making sure your tissues get the oxygen they need.
And that leads us to those synthetic versions of EPO, like apoietin alpha, Epigen, Procrit. What are these used for, and what should someone know about them if they need them?
Right. Apotin alpha is basically a man-made copy of your body's natural erythropoietin. It's used mainly to treat anemia, that shortage of red blood cells, especially in folks with chronic kidney failure. Their kidneys aren't making enough natural EPO, so this steps in. Now, there are some things to keep in mind, though.
Yeah, there are those side effects and that black box warning.
Yeah. So common ones are high blood pressure, headache, fever, the usual suspects, nausea, diarrhea, sometimes swelling. But that black box warning is serious. It warns about a higher risk of, heart and blood vessel problems. You're talking like TIAs, mini strokes, heart attacks, and strokes, especially for dialysis patients with chronic kidney failure who are on apoietin.
That sounds really scary. Are there situations where it shouldn't be used at all?
Yeah, absolutely. So generally not for folks with uncontrolled high blood pressure or certain blood cancers called myeloid malignancies. The concern is it might fuel the growth of those cancerous cells.
And practically, how about not shaking the vial and needing iron supplements?
Right. Shaking the vial can damage the drug, so handle it with care. And iron, well, since apoietin alpha is telling the bone marrow to make more red blood cells, you need the building blocks for that. Iron's key. So iron supplements are often necessary. And just so you know, it's a pregnancy category C drug. We don't know all the risks for sure.
And what if someone accidentally takes too much? The notes mention phlebotomy.
Yeah. So if there's an overdose and way too many red blood cells are produced, that's called polycythemia, they might do phlebotomy. It's basically drawing blood to reduce the number of red blood cells and thin out the blood a bit.
Before someone starts on these erythropoiesis-stimulating drugs, it seems like a full checkup is needed. What kind of baseline assessments are key?
Oh, absolutely. We need the complete picture. Health history, especially any heart, lung, nervous system, liver, or kidney problems. What other meds they're taking, including alcohol, their weight, vital signs, especially blood pressure. And of course, the lab tests, CBC, coagulation studies, PHC, INR, iron levels like transferrin, serum ferritin, and checking how the kidneys and liver are functioning, to get a baseline and watch for changes.
Let's shift to white blood cells, or leukocytes.
Yeah.
Our source talks about colony-stimulating factors. How do these work differently than erythropoietin?
Okay, so colony-stimulating factors, or CSFs, they're another type of growth factor, but their focus is on white blood cells, the ones that fight infection. Think of it this way. EPO is for red blood cell production. CSFs are like the body's alarm system. They boost the production of those immune cells when needed. Now, it's worth noting that there are also these things called interleukins. They're another type of growth factor that modulate the immune system. But CSFs are about increasing those infection-fighting white blood cells.
And what's the main advantage of using these colony-stimulating factors medically?
So they can really shorten the duration of neutropenia, which is when you have dangerously low neutrophils, a specific type of white blood cell. That leaves people super vulnerable to infection, especially after chemo or a transplant. By boosting neutrophil production, these CSFs help reduce that risk and how long people are susceptible.
Okay. We've got two examples here. Filgrastim, that's Neupogen, and sargramostim, which is leukine. Let's start with filgrastim. What do we know about this one?
All right, filgrastim is mostly used to counteract neutropenia from chemo. Side effects, well, fatigue, rash, nosebleeds, sometimes a dip in platelet count, fever from the low neutrophils, that's neutropenic fever, nausea, vomiting, bone pain. In rare cases, there's a risk of splenic rupture, which is serious.
This sounds really serious. Any important things about giving filgrastim?
Yeah, a couple. Don't give it within 24 hours of cytotoxic chemotherapy, could mess with its effectiveness. And monitor neutrophil count regularly. You want it to rise, but also watch out for leukocytosis, too many neutrophils, which can cause problems in the lungs, brain, eyes, even the heart. Filgrastim can also raise uric acid levels, and it's a pregnancy category C drug.
And what about sargramostim, the leukine? How does it compare in terms of its role and side effects?
So sargramostim also increases leukocytes and reduces infection risk, but it's often used in people with leukemia or those who've had a bone marrow transplant. Side effects, you might see flu-like symptoms, fever, shortness of breath, nausea, vomiting, bone and joint pain, hair loss, fatigue. Important thing, don't give it within 24 hours of chemo or 12 hours of radiation.
So similar to filgrastim in terms of timing with other cancer treatments, what about baseline assessments before starting someone on any colony-stimulating factors?
Okay, so again, really thorough health history. Watch out for pre-existing heart conditions like irregular heartbeat or heart failure, lung, kidney, or liver problems, recent infections, past surgeries, injuries, even something like a yeast infection. Vaccination history is important. Also, their regular medications, any alcohol use, weight, vital signs, fatigue level. Lab work, you'd want a CBC with a differential to see the different white blood cells, kidney and liver function tests, uric acid, and an ECG to check the heart.
Now let's look at platelets, those tiny cells that make you clot. Our notes mention platelet enhancers like Oprovec, and that's Numega. What do they do?
Platelet enhancers boost megakaryocytes. Those are the cells in the bone marrow that make platelets. They also increase thrombopoietin, which regulates platelet production. So basically, you get more platelets, less risk of bleeding.
And Oprovec and the Numega is the main drug in this group. What's it used for, and what are the potential side effects?
Oprovec is mainly for people with thrombocytopenia, low platelet count, often after intense chemo. Side effects. You might see fluid retention, fever, headache, dizziness, shortness of breath, fatigue, rash, nausea, vomiting.
Okay, we've talked a lot about boosting blood cell production.
Yeah.
But what about when the problem is low oxygen carrying capacity?
Anemia, right.
Right, anemia. Basically, not enough healthy red blood cells, so less oxygen gets to the tissues.
Yeah.
And it can be from various things, blood loss, red blood cells being destroyed too quickly, or not enough being made. It's important to remember that anemia is often a symptom, so we need to find the underlying cause, like gastrointestinal malignancies or chronic ulcers, to really treat it.
What are the signs that someone might have anemia? You might see pale skin, pale linings of the mouth and eyes, decreased exercise tolerance, just getting tired easily, feeling fatigued, dizziness, lightheadedness, maybe even fainting. The heart might beat faster, breathing might speed up, the body's trying to compensate for less oxygen. And in severe cases, it can even contribute to heart failure. Our notes also point out that certain vitamins and minerals are crucial for preventing and treating specific types of anemia.
Okay, and our notes list 2 anti-anemic agents, cyanocobalamin, that's Nascobal, a form of vitamin B12, and ferrous sulfate, the iron supplement, Feosol. Let's start with cyanocobalamin.
All right, cyanocobalamin. It's a purified form of vitamin B12, and that's crucial for healthy red blood cells and good nerve function. Side effects can include low potassium, diarrhea, rash, joint pain, dizziness, headaches. Rarely you might see anaphylaxis, which is a severe allergic reaction. It's not generally recommended for people with severe lung disease or heart problems because of the sodium retention possibility. If you mix it with fruit juice, give it quickly. And pregnancy category. A, generally safe except for IV use, which is C, meaning there could be risks.
And what about ferrous sulfate, the iron? We need that for hemoglobin, the protein that carries oxygen in red blood cells.
Right, ferrous sulfate. Good iron supplement, but can have some side effects, GI upset, nausea, cramps, diarrhea, dark stools, but that's harmless. You might see constipation too. In serious cases, cardiovascular collapse or worsening of ulcers. Iron toxicity is a big worry, especially in kids. Accidental overdoses can be fatal. There's a black box warning about that. Don't use it if someone has hemochromatosis, that's too much iron, or ulcers or inflammatory bowel disease.
Wow, that black box warning is serious, especially about children. What about the practicalities of using ferrous sulfate? There are a lot of instructions.
You're telling me. Lots to remember. So regular hemoglobin and hematocrit checks, blood tests, are a must to make sure the iron is working and not causing overload. IV. Watch out for infiltration. Iron can really irritate tissues. IM injection. Use the Z-Track method to prevent leakage and staining. Best absorbed on an empty stomach, but if it causes too much stomach trouble, take it with food, but absorption goes way down, like 50 to 70% less. Don't take it close to bedtime either. Avoid esophageal irritation. And don't mix it with antacids, proton pump inhibitors, aluminum salts, sodium bicarbonate, or calcium supplements. Wait at least 1 to 2 hours. They mess with absorption. Iron can also affect some antibiotics like tetracyclines and fluoroquinolones, making them less effective. It can lower calcium and raise bilirubin levels too. While many foods can decrease iron absorption, vitamin C actually increases it, although it might make GI side effects worse, and is pregnancy category A.
And if someone overdoses on iron, deferoxamine is the treatment, right?
Yep, deferoxamine, Desferal. It binds to the excess iron and lets it be excreted in the urine, which might turn reddish-brown.
And what about those baseline assessments before giving any anti-anemic agents?
Like we've been talking about. Health history, the reason for the drug, and especially a good look at the CBC, specifically hematocrit and hemoglobin.
Our notes also mention intrinsic factor and how it's needed for vitamin B12 absorption. What's the connection there?
Intrinsic factor. It's this protein made in the stomach, and it's basically a VIP escort for vitamin B12. It binds to it and makes sure it gets absorbed properly in the small intestine. If you don't have enough intrinsic factor, even if you're eating enough B12, your body can't use it, and you end up deficient.
What causes a lack of intrinsic factor?
A few things. Inflammation in the stomach surgery, even strict vegetarian or vegan diets without reliable B12 sources. Sometimes you can actually supplement intrinsic factor itself, along with B12 injections.
And what are the important baseline assessments if you suspect an intrinsic factor issue?
The usual health history, focusing on any heart, GI, liver, or kidney problems, medications, alcohol use, weight, vital signs, fatigue level, and lab tests, CBC, electrolytes, transferrin, serum ferritin to check iron, and liver and kidney function tests.
Okay, we've talked about how the body makes blood cells and how to boost production or address shortages. Now, a big chunk of our source material focuses on neoplasia, which is cancer and its treatment. Big topic, but can you give us the overview?
Sure. So neoplasia, or cancer, is when cells divide uncontrollably. These abnormal cells lose their normal functions and can invade other tissues. And when they break away from the original tumor and spread, that's metastasis. A tumor, or a neoplasm, can be a solid mass, like a breast tumor, or it can be spread out, like in leukemia, which affects the blood. Cancers are named based on the tissue they come from, like lymphoma, which starts in the lymph system.
And what causes cancer? Our notes mention these things called carcinogens.
Right, carcinogens. They're the things that can trigger cancer. They can be chemical, like stuff in tobacco smoke or asbestos, physical, like UV radiation from the sun, or X-rays, or biological, like viruses like HPV. Other things that can contribute are a weak immune system, inherited genes that increase risk, like oncogenes, or damage to genes that normally prevent cancer, the tumor suppressor genes.
Besides medications, what can people do to lower their risk?
Healthy lifestyle's huge. Don't smoke, limit alcohol, eat a balanced diet, lots of fruits, veggies, whole grains, less processed foods, saturated fat, red meat. Exercise regularly to stay at a healthy weight. Sun protection's important too. And be proactive. Self-exams, regular cancer screenings like mammograms, colonoscopies, pap smears. Early detection makes treatment more successful.
Speaking of treatment, chemotherapy is often a big part of it. How does it fit into the overall picture?
So chemotherapy uses drugs that travel through the bloodstream to reach cancer cells throughout the body. Some can even get into the brain. Sometimes chemo drugs are put directly into body cavities like the bladder. Surgery removes tumors. Radiation uses energy to kill cancer cells in a specific spot. Chemo can be used to try to cure the cancer, to ease symptoms when a cure isn't possible, that's palliative care, or even to prevent cancer in high-risk people, that's chemoprophylaxis. It's often used after surgery or radiation to kill any remaining cancer cells, which increases the chances of a cure. We call that adjuvant therapy. And the ultimate goal is a total cure, getting rid of all the cancer cells.
There's something in our notes called the growth fraction of tumors. What is that, and why is it important for chemo?
Growth fraction is basically how many cells in a tumor are actively dividing compared to resting cells. Chemo works best against cells that are dividing, so tumors with a high growth fraction, like leukemias and lymphomas, tend to respond better to chemo. Solid tumors often have a lower growth fraction, they're less sensitive.
So that's why chemo often affects normal, fast-dividing cells like hair follicles, bone marrow, and the lining of the GI tract.
Exactly. Those cells also have a high growth fraction, hence the side effects, hair loss, anemia, and higher infection risk from bone marrow suppression, nausea, vomiting, mouth sores.
What are the main principles behind using drugs to treat cancer? It seems very carefully managed.
Oh, it is. A big thing is using multiple drugs. It allows you to hit the cancer cells at different points in their cycle, using different ways to kill them, which makes them less likely to become resistant. It also means lower doses of each drug, which can reduce side effects. But a big challenge is that you often can't kill the cancer cells without harming normal cells, so we have to monitor closely and adjust doses. Bone marrow suppression is a common side effect, sometimes requiring a bone marrow transplant, blood transfusions, or growth factors to help recovery. Then there are vesicants, chemo drugs that can severely damage tissue if they leak out of the vein. That's an emergency. And some chemo drugs have long-term risks, like infertility and secondary cancers years later.
Our source lists different classes of antineoplastic drugs. First up, alkylating agents, with cyclophosphamide, Cytoxan is the example. How do these work?
Alkylating agents attack the DNA of cancer cells, preventing them from dividing. They work on a variety of cancers, but bone marrow suppression is a big side effect.
And cyclophosphamide is used for a bunch of cancers: Hodgkin's and non-Hodgkin's lymphoma, multiple myeloma, breast cancer, ovarian cancer. What are the side effects, and what should nurses know?
Common side effects are nausea, vomiting, loss of appetite, diarrhea, hair loss, sometimes bleeding from bladder inflammation called hemorrhagic cystitis, low platelet count, weakened immune system, and even the risk of becoming infertile, especially with long-term use. Don't use it if someone has an active infection, very low blood cell counts, or if they're taking certain meds that can increase toxicity like allopurinol, blood thinners, other immunosuppressants, even St. John's wort. When giving it, dilute it properly for 5e, watch the IV site, and hold it if platelet count's too low. Give it with food or in divided doses to help with stomach upset. Watch out for interactions with insulin, thiazide diuretics, digoxin, and check uric acid levels. It's pregnancy category C. Tell patients to avoid crowds and sick people, drink plenty of fluids, report any hearing changes, and be extra careful about hygiene.
Next are antimetabolites, with methotrexate, Rumitrex as the example. How do they work?
These drugs are sneaky. They look like the building blocks cells need to make DNA and RNA, fooling the cancer cells into taking them up. Once inside, they interfere with DNA and RNA synthesis, stopping the cell from growing and dividing. Methotrexate specifically blocks an enzyme needed for folic acid, which is essential for cell growth.
Methotrexate is used for various cancers and autoimmune conditions. What are the serious side effects and warnings?
Some serious side effects are increased risk of bleeding and bruising because of low platelet count, nausea, vomiting, loss of appetite, GI ulcers, and bleeding. It has a few black box warnings. It can cause fatal bone marrow toxicity, especially at high doses or with NSAIDs. It can also damage the liver, even leading to cirrhosis with long-term use. Other risks are intestinal perforation, a lung infection called pneumocystis pneumonia, severe skin reactions, kidney failure, and even lymphoma. Don't use it in people with low blood cell counts, alcoholism, liver disease, breastfeeding mothers, or those with certain blood disorders. Avoid skin contact and inhaling the powder. For FiOV, dilute it properly and watch for extravasation. It can increase uric acid levels, and food delays absorption when taken orally. Good oral hygiene is important during treatment. And it's pregnancy category X, absolutely not for pregnant women. If there's an overdose, leucovorin can help.
Now we have antitumor antibiotics. The example here is doxorubicin, adriamycin. They're called antibiotics, but they kill cancer cells differently than they kill bacteria, right?
Right, they're not fighting infection here. Antitumor antibiotics kill cancer cells by damaging their DNA, kind of like alkylating agents, but they have their own ways of messing with cancer cell growth. But a big problem with them, especially doxorubicin, is that they can damage the heart. That's cardiotoxicity. It can cause irregular heartbeat, and it can happen during treatment or even years later. Doxorubicin also often causes low blood cell counts, nausea, vomiting, hair loss. It has a few black box warnings, risk of secondary cancers, cardiotoxicity, severe bone marrow suppression. Don't use it during pregnancy or breastfeeding if someone already has bone marrow suppression or low platelet count, heart disease, obstructive jaundice, or if they've already had the maximum lifetime dose of similar drugs. Extravasation is a big risk, can cause serious tissue damage, needs to be treated immediately, usually with ice. Avoid skin contact, wear gloves when handling it. It can also increase uric acid and liver enzymes and decrease blood cell counts and digoxin levels. Some drugs, like St. John's wort and phenobarbital, can make it less effective, while verapamil can make it more toxic. Get a baseline ECG before starting. And it's pregnancy category D. For overdose, supportive care is key. Antibiotics to prevent infection, platelet transfusion if needed, and symptom relief.
The next category is natural products, specifically plant extracts that stop cell division. Vincristine, oncovin is the example.
Vincristine messes with microtubules, these structures inside cells that are crucial for cell division. By stopping them from working, it stops the cancer cells from dividing. It's used for Hodgkin's and non-Hodgkin's lymphoma, leukemias, Kaposi's sarcoma, Wilms tumor, bladder, and breast cancer. One big side effect is neurotoxicity. That means it affects the nerves, causing numbness, tingling, weakness, nerve pain, constipation, and in bad cases, paralytic ileus, where the gut stops working. Hair loss is common too. It has a black box warning for myelosuppression, but it usually causes less of that than other chemo drugs. Don't use it in people with obstructive jaundice, active infection, liver radiation, or breastfeeding mothers. Extravasation's a risk if it happens. Stop the injection, apply heat, and inject hyaluronidase to help disperse the drug. Keep it away from the eyes. It can also increase uric acid and decrease digoxin and phenytoin levels, which can increase seizure risk. Check for any plant or flower allergies, could mean a higher risk of reactions. Watch out for rashes, breathing problems, and signs of depression. Prednisone, a steroid, can increase its bone marrow toxicity. It's pregnancy category D. Overdose is very serious, might be fatal. Leucovorin might help, but it's not guaranteed.
Our next category is hormones and hormone agents, with tamoxifen being the key example. These are supposed to be less toxic than standard chemo, right?
Yeah, they basically tweak the body's hormones to slow or stop the growth of tumors that depend on hormones. Tamoxifen, for example, blocks estrogen in breast cancer cells. It's mainly used for estrogen receptor-positive breast cancer. Common side effects are nausea, vomiting, hot flashes, fluid retention, vaginal discharge, high blood pressure, swelling. Sometimes the tumor might get bigger at the start of treatment. That's called a tumor flare, but it usually means the drug is working. But there are some serious black box warnings, increased risk of endometrial cancer and blood clots, like stroke, pulmonary embolism, DVT. Don't use it if someone's on blood thinners, has endometrial hyperplasia, history of blood clots, certain blood disorders, vision problems, or cataracts. It can increase bleeding risk with blood thinners, and estrogens can make it less effective. It might increase calcium levels, too. It's important to talk to patients about possible masculinizing effects and the risk of infertility. Take it with food or drink to help with stomach upset. Don't take it at the same time as antacids, and it's pregnancy category D.
And lastly, we have biologic response modifiers. They're all about using the body's own immune system to fight cancer.
Exactly. They include interferons, interleukins, and monoclonal antibodies. Some directly stimulate the immune system to attack cancer cells. Others help the immune system work better. They tend to be less toxic than regular chemo and are often used alongside other anti-neoplastics to reduce the overall immunosuppression. The goal is to make the body better at finding and killing cancer cells.
Our notes also mention a whole bunch of other nursing diagnoses that might be relevant for people going through cancer treatment.
Right. Cancer care involves looking at the whole person. We have to think about things like risk of infection, fatigue, anxiety, depression, social isolation, changes in weight and nutrition, dehydration, diarrhea, constipation, mouth sores, skin problems, pain management, difficulty managing their treatment plan, feelings of hopelessness, spiritual distress, lack of knowledge about their disease and treatment, risk of heart problems, risk of injury and falls, and even the burden on caregivers.
And before starting anyone on these anti-cancer drugs, a thorough assessment is crucial. What are the key baseline things to check?
You have to get a complete picture of the patient's health. Detailed health history, looking for any problems with the nervous system, heart, lungs, liver, kidneys. Full medication history, including over-the-counter drugs, supplements, and alcohol. We need to know if they're pregnant, their vaccination history, especially for live vaccines, any signs of infection, history of shingles or chickenpox, their weight, vital signs, how tired they are, and any pain they're experiencing. For lab tests, CBC with platelet count, urinalysis, liver and kidney function tests, uric acid, electrolytes, and blood sugar.
So we've covered a lot today. Hematopoiesis, the process of making blood cells, how to stimulate it, how to address deficiencies, and a whole overview of cancer and how we treat it. From the basics of how blood cells are made and the role of growth factors to the specifics of erythropoiesis-stimulating agents, colony-stimulating factors, platelet enhancers, and anti-anemic agents. And then understanding cancer, the different types of anti-cancer drugs, how they work, and the things we have to watch out for, like bone marrow suppression and specific toxicities. It's a lot to take in.
It is, but now you have a much better understanding of how these essential parts of your body work and the amazing ways medicine can help support and regulate them.
It's fascinating to think about this delicate balance between stimulating blood cell production and managing those potential side effects, and the complex strategies used to treat cancer.
Yeah.
It really highlights how intertwined medical interventions are with the body's own natural systems.
What do you think all of this says about our attempts to influence and sometimes even fundamentally change these basic biological processes? It's a really good question. And for our listener, if you're curious about how specific drugs work or the details of different cancer treatment protocols, I encourage you to dig deeper. There's always more to learn about these important aspects of human health.